चालू आवाज कहाँ से इसकी?
नवनीत जी, वो दीपक झा सर को को-होस्ट बना दीजिए प्लीज।
यस सर।
हर्ष, गुड इवनिंग।
यार, क्या हाल है?
बस बढ़िया।
आई थिंक दोनों ने ज्वाइन कर लिया है, इफ आई एम नॉट रॉन्ग। वर्तिका हैज ज्वाइंड एंड विमल हैज आल्सो ज्वाइंड। अमोल सर हैज आल्सो।
ये तुम बैठ जाओ, ज्वाइन करो उधर से।
ओके। सर गुड आफ्टरनून। अमोल सर।
All set?
हाँ सर, जस्ट मे बी 1 minute 2 minutes विल स्टार्ट। गुड
Yeah.
आफ्टरनून झा सर, जस्ट 2 minutes में विल स्टार्ट।
Good afternoon.
आफ्टरनून सर।
Sir, good afternoon.
शेयर हो रहा है ना पुनिया? यू कैन सी।
हाँ, हो रहा है।
चालीस 2 मिनट और रुक जाते हैं, विल स्टार्ट।
ठीक।
By the time the participants can just share their PPT, see if there is any problem in sharing something. Both of you, one by one. Yeah, Vimal, we can see yours.
Yes,
You can unshare now.
Is it visible?
yes,
Yeah,
yours is
yeah.
visible too.
Okay. So you keep sharing, Vardhya. You hold on. We'll start from you.
So Harsh, once again, please let everyone that the examiners know the rules.
Yes, sir. So, Jha sir and Amol sir, we have explained this before, but just for everyone, candidate one will be presenting first. In this case, Dr. Vartika will be presenting first. The candidate who is presenting will be evaluated only on the presentation that she or he is making during the presentation. However, all the questions regarding the case will be directed to Dr. Vimal or candidate B. And while Dr. Vimal is presenting, all the questions will be directed to Dr. Vartika. The reason behind this is obviously both of them would have prepared their own cases, but it is very unlikely that they have prepared each other's cases. And in the exam, you can get anything out of the blue. And so the preparation is just for the exam. So when Vartika is presenting, all questions related to the topic, for example, if she's presenting AAD, will be directed to Dr. Vimal. However, if there is a problem in the presentation, she has not taken history completely, or you feel that there should have been something which should have been asked more, that points will be deducted from Dr. Vartika's presentation. All of these would be ultimately used to evaluate for the Best Resident Award, which will be done in YNF next year now. This is the next year cycle which is starting. This year cycle already has completed, and five of these students, one of whom I can see in the participants, I think Dr. Pranomita had joined, she has been selected as one of the participants for the Best Resident Award. So with this, sir, Amol sir and Jha sir, you can both take leads in one of the cases.
If Vimal is unable to answer, the question goes back to Vartika.
Yeah, if Vimal is able to answer. So, Vartika, you can go full screen and we can start now.
Yes, sir.
You have 45 minutes to complete your presentation, after which we will shift to Dr.
Yes, sir. Sir, is it visible now?
Yes, Dr. Vartika, we can see.
Good morning, good afternoon, everyone. I'll be present.
You can make it full screen, I think.
Yes. Is it better?
Yeah, perfect.
I'll be presenting a case of 34-year-old female who's a Hindu by religion and housewife by profession belonging to Alwar, Rajasthan. She is a right-handed female and history is given by self and her husband and is reliable. She presented to us with the history of progressive decrease in vision in bilateral eye since last 10 years, right more than left, with worsening over last 2 to 3 months. She also complains of double vision since last 2 months, especially on seeing the right lateral side, and drooping of right eyelid since last 2 months, and headache since last 2 months. Coming to the history of presenting illness, patient was apparently all right 10 years ago when she first noticed difficulty in seeing objects from side. Initially, the visual difficulty was subtle and intermittent. She would occasionally bump into objects, particularly while walking into crowded places, and had difficulty in noticing in people and vehicles approaching from the periphery, especially from the right side while driving. These symptoms initially were mild and did not interfere with her daily activities at the time.
Okay, Vartika, just 1 second. Can you go
Yes,
back
sir.
to chief complaints?
Yes, sir.
So just a question to Dr. Bimal.
Yes, sir.
Based on the chief complaints, can you sort of ballpark, give an idea that, where the lesion is located anatomically
So,
and what it can be?
yes, sir. Since the patient
Earlier
has
mentioned,
got,
but yeah, okay.
since the patient has got decrease in the vision with the two, especially on from the sides, there is a difficulty. I can localize the lesion from the history to the suprasellar region, sir.
Okay, what else can you decipher?
And there is drooping of the right eyelids,
Mhm.
but it is not a sudden onset. It's been there for 2 months. So there is a probability of the involvement of lesion to the right side of cavernous sinus probably, or if in case if it is suprasellar lesion with a probable etiology of a pituitary, patient would have gone into some features of apoplexy causing drooping of right eyelid.
So basically, it's a suprasellar as well as parasellar involvement.
Yes, sir.
Till now, we don't have any clear-cut history of whether it's sellar involvement or not.
Yes,
Okay.
sir. Yes, sir.
Okay. Please, Dr. Vartika, please proceed.
So over the years, the visual symptoms have progressed slowly and insidiously. The decrease in vision was painless, gradual, and progressive. Over the last 2 to 3 months, patient has noticed worsening of vision and has reported more frequent collisions with objects and needs constant head turning to look at the objects. There is no history of sudden vision loss, transient visual obscurations, complete or partial blindness episodes, diurnal fluctuation of vision, floaters, halo around lights, visual distortion, ocular pain, redness, watering or discharge, trauma to head or eye, prior ocular surgery, or painful eye movements. Over the last 2 to 3 months, patient has developed double vision, which was gradual in onset, progressive and painless. It
Okay,
was
Vartika,
binocular.
I'll just stop you for 1 second again.
Yes,
So,
sir.
Dr. Vimal, can you tell any other history which could have been relevant for the past 10 years, which Dr. Vartika has missed, or would have added to your sort of clinical understanding of the patient's localization? Any other history that you would like to take, which is pertinent?
Yes, sir. So the pattern of the patient developing blindness, I mean, like the difficulty, whether it was ascending type, whether she was able to difficulty in seeing the objects from below to above, or there was a obscuration of vision from above to below. So I can interpret whether the lesion could be a possibly from a cellular to a supracellular, or it is ascending from a supracellular below down.
Mm. Okay. Anything else? Because we were discussing about whether the lesion is just supracellular, paracellular, or is it cellular. So do you want to take any history related to whether there is involvement of cella itself and anything relevant to it? Because it's been 10
So,
years.
so
Yeah.
since she is a female, I would like to ask about any history of menstrual disturbances,
Yes.
galactorrhea, and any infertility, whether she has taken any treatment for infertility or something like that, sir.
Yeah. So that's very important. And apart from that, history of hypothyroidism
Yes, sir.
or
Yes, sir.
hypocortisolism, other symptoms. I mean, you can have an history of both the reduce in production and sometimes increase
Increased
also.
production, both.
So you have to take relevant. So Dr. Vartika, you have to take all these relevant history with
Sir, I have mentioned it afterwards,
you
actually.
afterwards. Okay. But I mean, since the time lag between the initial symptoms for the many 10 years to you're coming to 2 months. So I think I would rather take that history also in consideration, even as a negative part at that point of time. But I think it's fair enough. Please proceed.
Over the last 2 to 3 months, patient has developed double vision, gradual in onset, progressive, painless, binocular, and disappeared on closing either eye. Double vision was more horizontal with side-by-side images, and it was more pronounced while looking towards the right side. No history of vertical double vision images, shaking surrounding sensation, fluctuation during the day. It was not associated with any fluctuation or fatigue, and it was not improved with rest. There is no history of trauma preceding the onset of double vision, or no history of eye pain, redness, swelling, or discharge.
Okay.
Then,
Dr.
yes.
Dr. Vimal, can you
Yes, sir.
analyze the history of double vision and so what it sort of helps you further in narrowing which particular cranial nerves are involved and what is not?
So the patient has developed a double vision, that too more on seeing horizontal with side to side, sir. So probably sixth nerve involvement could be there. And patient has got drooping of the eyelids. So the oculomotor nerve, I mean the V1 division of trigeminal nerve could also be possibly involved.
Okay. What is the particular history if a patient has a trochlear nerve involvement? What kind of symptoms in history would like to ask for?
Uh,
Okay, going back to Dr. Vartika, can you tell?
So vertical double images are present or not?
So the history would be, while climbing down the stairs, the patient typically has difficulty in having both the eyes working synchronized in a synchronized manner, and that is a typical history that they tell that difficulty in walking down the stairs. Okay, so
Yes.
that's very important to ask and specify in the history because it's probably one of those very rare things where you can pick up a subtle trochlear palsy also. Okay, any other history you would like to take, Dr. Vimal, in a negative history or any other relevant history for the double vision?
So any features suggestive of raised ICP, sir? I would like to ask because since there is a long-term history of this double vision, I would like to rule out intracranial pressure to see the extent of the tumor into the third ventricle or not, or other features of hydrocephalus is there or not.
Okay,
Any early morning
but yeah,
vomiting.
but that might come later along with the negative history, I feel, Dr. Vartika.
Yes, sir.
But yeah, it's relevant. And so, I mean, another thing you should ask, okay, Dr. Vartika, anything else that you feel now at this point that you could have asked and added before I tell that?
No, sir.
Okay, so you should take an history of whether the double vision goes away while closing one of the eyes or not with your
Sir, I
hand.
have
You have?
taken that history, yes. So
Maybe I missed that part.
it it did not disappear on closing either eye.
Okay, disappointment. Okay, so that's important. Okay. So that's relevant, and that separates an ocular pathology from a neural pathology. So I think that's
Yes.
fair enough. Okay, good. Proceed.
Uh, Patient noticed drooping of right eyelid since last 2 months. It was gradual in onset, slowly progressive. It was initially mild, but it became more noticeable over the past 2 months, and it is persistent throughout the day. There is no history of diurnal variation, fatigability, improvement with rest, eye pain or redness, difficulty in chewing or swallowing. There is no history of any speech difficulty or facial weakness. And this is for drooping of eyelids.
Okay. Yeah, Dr. Vimal, now analyze this symptom for me.
So the patient has no history of fatigability. There is no improvement with rest, which rules out hypothyroidism, and there is no eye pain, redness, which rules out any features of orbital apex or cavernous sinus syndrome, and difficulty in chewing, swallowing, which rules out trigeminal nerve involvement. And yes, sir.
Okay. Fatigability and diurnal variation. You feel what exactly is this relevant to? And hypothyroidism for this patient or something else? So think about a non-neurosurgical cause which can cause,
Myasthenia gravis, sir.
yeah,
So which is more
absolutely.
prominent to see in
Okay,
the
so it's
yeah
myasthenia gravis typically happens,
yeah
you'll
towards
have,
the end of the day.
yeah, exactly, because your acetylcholine sort of reserve
Yes,
goes down as the day goes, and the eyes become more fatigued and the double vision gets more noticeable in the evening. Okay,
yes, sir.
okay, good. Okay, uh, Dr. Jha, sir, please ask anything else at any point.
Go ahead, go ahead. You are asking relevant questions. Okay, go ahead, please.
Right, sir. Oh,
Patient complains of headache since last 2 months. It was insidious in onset, gradually progressive. It was initially intermittent and lately it has become more frequent for the patient. The character of the pain was dull aching. It felt more like a pressure. It was more over the frontal and retroorbital region. It was bilateral, it was non-throbbing in nature, and it was partially relieved with oral analgesic. There was no history of early morning headaches or postural headaches. It did not worsen with coughing, sneezing, or straining. There is no history of projectile vomiting, seizures, altered sensorium, fever, neck stiffness, photophobia, phonophobia, or sudden severe headache.
okay. So, Dr. Vimal,
Yes,
based
sir.
on all the relevant history that Dr. Vartika has told about all the chief complaints, do you feel that you're more knowledgeable as compared to just the chief complaints? And
Yes, sir. So I could feel that there is a cellular lesion which is, I mean, stretching the, I mean, the dura over the diaphragma cellar probably, if it is a pituitary, causing the aching headache. And she has mentioned it is more over the frontal region, which the diaphragma cellar is obviously supplied by V1 division of trigeminal nerve. So the pain is more over there. And yes, sir.
Can it be only by supracellular lesion? Is there any symptom of sella in addition to pain, headache?
So I can't get you, sir.
Any stock effect?
Yes, sir.
Is there, can the pain, headache be due to non-cellular reason with all these symptoms? Can there be only supracellular lesion? This is the question. Without cellular involvement.
With features of hydrocephalus presenting, sir. Any
No.
supracellular.
The headache is mild, frontal, what she said. Exactly the same features. Can it be only due to non-cellular supracellular lesion, not cellular involvement?
Not sure.
No. Why? What is against that? Tuberculum celli or diaphragma celli lesion, which goes upwards, can it be caused by a lesion there?
It can be caused, sir, but
Can be
not.
caused, na?
Yes, sir.
So, do you, till now, whatever she has said, could you find anything else in addition to pain which suggests pituitary or pituitary negative stock effect or something? Anything like that? No.
No, sir.
No. So it can be supracellular also.
Yes, it can be
Midline
supracellular.
supracellular slightly more towards right.
Yes, sir.
Is that true?
But there are no other symptoms suggestive of only a suprasellar lesion, sir.
All the symptoms are there, chiasmatic compression.
Yes.
So what is against suprasellar lesion? There is one thing which is against suprasellar.
I mean, the development of pain only in the frontal
No, no,
region.
no, 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 no. Everything can be there in suprasellar lesion, except one kind of which cannot be involved in suprasellar lesion. Which one is that? You have got two kernels which is involved in three kernels which is involved in, which are involved in this
Yes, sir.
whole presentation. What are those nerves? Second, third, and fourth.
Yes, sir.
Second, third, and fourth. Agree or
Yes,
disagree?
sir. Agree, sir.
So which kernel cannot be involved in suprasellar lesion? At this location.
Fourth nerve cannot be involved only in a suprasellar lesion.
Fourth cannot be involved there. No? It will be difficult. It has to go much posterior.
Yes, sir.
Okay, go ahead.
Sir, there was no history of any galactaria, breast enlargement of pain or infertility, no history of increase in shoe size, ring size, excessive sweating, joint pain, or hoarseness of voice or jaw protrusion. There was no history of any progressive weight gain, facial rounding, easy bruisability, proximal muscle weakness, or recurrent infections, or poor wound healing. There is no history of chronic fatigue, weight loss, nausea, vomiting, or hyperpigmentation. There is no history of cold intolerance, weight gain, dry skin, constipation, hair loss, or bradycardia. There is no history of any heat tolerance, palpitations, weight loss, or tremors, or increased bowel frequency. And there is no history of any excess of thirst, polyuria, nocturia, or passage of large volume dilute urine. There is no history of any limb weakness, sensory loss, hearing loss, vertigo, tinnitus, gait imbalance, and falls. So should I proceed?
Yeah, okay. So, Dr. Vimal, can you tell what are the differential diagnoses so far?
So it is a
What would you keep as a first differential, a
first
second
will be
differential,
a
third,
pituitary
and a fourth?
macroadenoma with a suprasellar extension, sir.
Microadenoma or macroadenoma.
Pituitary macroadenoma with suprasellar extension, sir.
Okay.
Go ahead. Continue.
Why Sella? I mean, why are you saying only pituitary?
So no, my first differentials would be pituitary macroadenoma with a suprasellar extension. So second I'll go with cranio, a suprasellar lesion extending into the sella probably. And third, it could be a rachis cleft chest coming down the lane. So
Okay, so craniopharyngioma, have you seen any cavernous sinus involvement with
no, so it
third
is very rare, sir.
and sixth involvement? So it's very
What
unlikely.
is the reason in addition to pituitary which usually involves cavernous sinus?
Yes, sir.
That should be the second now. Which one is? Okay, go ahead. First was pituitary macroadenoma. What should be second? That case cleft sit craniopharyngioma. These do they produce with features of cavernous sinus involvement?
No cavernous sinus involvement will be there, sir.
And what are the other lesions which present with cavernous sinus involvement also?
So it can be a cavernous sinus hemangioma.
Unilateral. The lesions, the
Yes,
signs,
sir.
all the symptoms are bilateral. Most of the symptoms are bilateral.
But most of the symptoms are towards the right side, sir. So there can be a rising from the right cavernous sinus and
And
compressing on the other side, sir. It
compressing
can
other
be
side, kaise? Is it possible? One
uh,
cavernous sinus lesion will compress optic nerve of other side.
rare. It can be a tubercular cell meningioma, sir.
Bitemporal hemianopia. This was the first symptom, na?
Yes, sir.
So where did the lesion first compress the structure?
In the midline.
Midline.
Yes, sir.
You have to think something in the midline, na, which later went to the right side more. So pituitary. What should be the other differential which do occur at these places?
Tubercular cell meningioma, sir.
Okay, and go ahead, continue.
Yeah, keep gaining differentials.
Or it can be a OCHG can also be a possibility, sir. Optic-chiasmatic hypothalamic glioma.
Again, optic-chiasmatic hypothalamic glioma, do you see, I mean, have you seen any cavernous sinus involvement? I mean,
No,
first of all,
very
is it an intraaxial pathology or an extraaxial pathology?
intraaxial pathology.
So, intraaxial pathology, how would, and is cavernous sinus an intraaxial, I mean, is it like situated within the brain or outside the brain?
It's outside, inside the brain.
Outside, right?
Yes, sir.
So, how do you think cavernous sinus involvement? Because, based on history, you're saying more of a unilateral cavernous sinus involvement with pituitary. That's understandable. But then your diagnosis should be an invasive pituitary with right side paracellular involvement as well, first thing. The
Yes,
other
sir.
thing would be you need to, like Dr. Jha is saying, that you need to apply your common sense, and based on the pathology which is more common when you are telling a differential diagnosis and which can sort of fit into this picture. So keep going. And again, you should when you're giving differential, so neoplastic is one pathology. You should think about other pathologies also. Okay,
Yes, sir.
inflammatories, etc., infective, and all those things. So you should always your differential should have a wider spectrum, and it should be easy to catalog them into different places. So the idea is for us to understand that how your mind analysis, analytical process is, being taken. That's the most important thing. So do you want to give another guess, or shall we ask Dr. Vartika?
Tuberculoma can be also a possibility.
Yeah, tuberculosis can present like anything. But
Yes,
of
sir.
course, it's a long history without any ATT or other things.
Mhm.
That's there. Dr. Vartika, any other differentials you would, because since you have worked up this case and you are the more, you would like to, you want to add some more differentials?
The clinoidal meningiomas can be one,
Yeah.
and clinoidal and paraclinoidal meningiomas can be one. And then we can also think along the path of optic nerve gliomas, since that was the first pathology.
No, I told you, no, optic nerve gliomas cannot involve cavernous
Yes.
sinus, so it won't fit into the whole picture.
So
What else?
these are clinoidal meningiomas, and then tuberculum sella and diaphragmatic sella meningiomas can be another.
Any pathology which arises from bone?
Chondromas.
Yeah. Tell Vimal, what do you think?
Chondromas can also be a possibility, sir.
Not chondromas.
Chordomas, sorry.
Chordomas.
Chordomas and chondrosarcomas, right?
Yes, sir.
Yes.
So those become your another differential here in this
On
case.
cartilage, dura, and structures within the cavernous sinus or cell. ठीक?
Right. Okay.
Go ahead.
Yes. The past history was not significant. Personal history diet was mixed with normal bowel and bladder movements. Sleep was undisturbed. Habits were none. Family history was not significant. Menstrual history, she had regular periods. Her LMP was 15 years back, and she was G0, P0, L0, and A0. Summarizing, she's a 34-year-old female with a 10-year history of slowly progressive, painless bilateral right more than left vision deficit, with worsening in the last 2 to 3 months, and development of binocular horizontal diplopia on the right lateral gaze, progressive drooping of right eyelid, and insidious onset frontal bilateral headache.
So last one, I forgot to ask you one thing. Did her diplopia changed after drooping of eyelid, or can she not see with her left eye?
So she
Drooping
can see with her left eye.
and after that, has the diplopia changed? The horizontal
No, sir,
images
not
are
according to her.
okay. Go ahead.
Coming to general physical examination, she examined true. She was moderately built and nourished with a BMI of 20.4. Her vitals were normal. There was absence of any central obesity, purple stria, palloricterus, cyanosis, clubbing, lymphadenopathy, edema, hyperpigmentation, breast enlargement, nipple discharge, thyroid enlargement, or sweating. Her systemic examination was normal. On examining the CNS, her MMSE score was 30 by 30. Cranial nerve 1 was intact. In cranial nerve 2, on doing the confrontation test, bitemporal hemianopia was present. Pupils were 3 mm equal and reactive to light. Visual acuity score for the right eye was 6 by 12 and for the left eye it was 6 by 9. Color vision was normal. Fundus examination was normal. On
Okay.
exam.
Second, Vartika. So, yeah, Dr. Vimal, can you tell any visual field examination which has a more objective connotation to it as compared to confrontation test?
Very good. Humphrey's visual field analysis, sir.
Okay. Anything else? Okay, Dr. Vartika.
The perimetry.
Now, perimetry may which tests?
Um,
Okay. Goldman's also. Okay. Read about it.
Goldman's perimeter.
Yeah. Okay. Please proceed.
Sir, on examining cranial of 3, 4, and 6, right eye, on examining the right eye, there was restricted abduction with mild ptosis. Examining the left eye, all movements were normal. Diplopia was worse on the right lateral gaze. Light reflex was normal. Accommodation reflex was normal, and there was no nystagmus. On examining cranial nerve 5, the
Vartika,
sensations were reduced in the.
just go back to the previous
Yes.
slide. Okay, Dr. Vimal, can you tell if you want to assess the trochlear nerve, what is the test and how do you do it?
So on examining the ocular movements of the eye, patient will have restricted movements towards the inferior. I mean, eye will be there will be a difficulty in superior superior. I mean movements and abduction movements, sir. So she might probably have an inward rotation of the eye, and there will be conjunctival vessel tortuosity. Tortuosity will be present, sir.
There's a very specific way in which you test the fourth nerve. Dr. Vartika, do you know that?
Sir, if we ask the patient to look towards the lateral side and we ask the patient to see towards the ground, so the function of the superior oblique becomes dominant and the patient is unable to depress the eye towards while seeing laterally.
Yeah, you need to refine it. It's okay. Read about it later. I think we are short of time. So, but it's an important aspect that you'll be asked in your real exams when you go down the line. So just read about it and be very, very clear when you tell that. Okay. All right. Please proceed.
Yes. On examining cranial of 5, the sensation were reduced in the V1 segment and right was more than left. V2 and V3 were preserved. Muscles of mastication were normal. Corneal reflex was absent on the right side, both direct and indirect, and left corneal reflex was normal.
Dr. Vimal,
Then rest of the cranial.
just go to the previous one. So, how would you infer this? The corneal reflex on the right side is absent in both direct and indirect.
So the V1 division of the trigeminal nerve is involved, sir, which carries the reflex from the ipsilateral cornea and results in the closure of the bilateral orbicularis ocular muscles.
Yeah, but
So
what about the
inside
seventh? What about the seventh nerve?
seventh nerve will result in unilateral difficulty in closure of the eye, sir.
No. So corneal reflex. Okay, what are the two limbs? What are the afferent and what is the efferent limb?
So afferent is by the fifth nerve and efferent is by the seventh nerve, sir.
Yeah. So what happens in the indirect reflex and what happens in the direct reflex for which eye?
So in the direct reflex, ipsilateral, when you corneal, when you try to touch the limbus of the eye, both the eyelids will close. So ipsilateral is taken by the trigeminal nerve, V1 segment of trigeminal nerve, and efferent is from the facial, which results in the closure of both the eyes, sir.
Yeah, you need to read about it. Okay, it's okay. Proceed. Next.
Rest of the cranial nerves were normal. Motor examination was normal. Sensory examination was normal. There were no cerebellar signs and gait was normal. Summarizing, she is a 34-year-old female with a 10-year history of slowly progressive, painless bilateral, more than left vision deficit, with worsening in last 2 to 3 months and development of binocular horizontal diplopia on right lateral gaze, progressive drooping of right eyelid, and new onset bilateral frontal headache with bitemporal hemianopia, right lateral rectus palsy, right corneal reflex affected with V1 right sensory loss and a mild right ptosis.
Okay. So, Dr. Vimal, based on this, after the examination that you have listened from Dr. Vartika, have you made it, has this made you any wiser, and how?
Yes, sir. So this confirms the presence of a probable non-functioning pituitary macroadenoma with suprasellar and parasellar extension, with involvement of V1 segment of the trigeminal and the oculomotor nerve, and later sixth nerve also, sir.
Yeah. Okay. Out of these cranial nerves, which is truly the content of cavernous sinus?
Abducent is a true content of the cavernous sinus, sir.
Yeah. Okay. And what what should be your first investigation of choice in this case?
So in this case, I would like to evaluate a hormone analysis first, sir. So to know what whether it is a secretory or a non-secretory pituitary tumor. So first, I would like to in the hormone analysis. First, I would like to go with prolactin, since the incidence is very high. Prolactin followed by serum cortisol, TSH, and growth hormone.
Okay. If the prolactin in the lab comes out as uh, 5 units, international units per annum, would you like to do something to reconfirm that value?
So I would like to go do a prolactin in dilution,
Mhm.
because sometimes very abnormally high prolactinomas can also produce a normal prolactin levels.
What is the phenomenon
So
called as?
hook effect, sir. So in this case, what happens is there will be antibodies should be sufficient to bind enough with the hormones. So I like to go with a prolactin dilution.
Okay, so it's serial dilution of the prolactin, so
Yes,
that you can actually truly assess whether it's prolactin secreting
prolactin
tumor.
secreting tumor.
Okay, so apart from the hormone profile, what else would be
So
your?
next, I will like to examine the optal examination of the patient to know what are the field deficits she has, and to examine the fundus, because I expected the patient to have a optic atrophy, since it is a long-standing history for 10 years. I expect the patient to have a primary optic atrophy. So then I would like to go with an MRI.
So
Uh,
what was the fundus examination finding mentioned here, Dr.
And
Vart?
it was normal.
It was normal as per you. And is it an arbitrary case, or was the patient really you examined and this was the finding?
No,
Because
sir, we also sent her to the ophthalmo PD and it was examined by the ophthalmologists and it was normal.
but you didn't do. I mean, did you try and look at it yourself?
Yes, sir, I did it myself as well and it was like normal.
So while doing fundus evaluation, which eye of yours did you use to assess the left eye of the patient?
So for assessing the left eye, I'll use my left eye as well. And for assessing the right, I'll use my right eye.
Okay. Okay. All
Then
right.
I'll go with an
Vimal,
ophthalmic
go ahead.
examination. Then I'll like to do an MR imaging of the brain with a specific sequence for the pituitary. So,
Okay. So how would you say, I mean, if you tell a technician that, or radiologist that what exactly sequence and what do you want?
so I would like to have a pituitary protocol MRI, which involves a dynamic contrast MRI and a post contrast MRI. And slices will be thin slices, or 1 mm cuts for the
So in the
pituitary.
dynamic sequence, what is the advantage and why would you want in this patient?
So the dynamic sequence helps in identifying the in visualizing the pituitary gland at various time intervals 0, 10, 30, and 90 seconds.
Is which particular type of pituitary tumors is the dynamic imaging relevant?
Most commonly in secretory pituitary. So,
No, no. Is it a microadenomas or macro?
microadenomas, it is very helpful.
So are you expecting a microadenoma in this patient?
No, not in this case, sir.
So then I mean, the dynamic sequences is actually not at all relevant here.
Yes, sir.
That becomes a relevant finding in secretory tumors if it's a
Tumors,
pituitary
yeah.
microadenoma, especially a Cushing's or a acro, and you want to see a microadenoma. So, and if since you have brought out this topic, so what is the exact thing that we are trying to look in the dynamic scan? What is the whole concept based on? A tumor versus a pituitary gland. What is the differential thing that we are looking at in that dynamic scan? Can you tell that?
The uptake of the contrast,
Is it the uptake or something else?
yeah, the different time intervals, the enhancing pattern of the cells.
No. Dr. Vartika, you want to add something to it?
Sir, we'll also see the excretory time of the contrast.
Yeah, so that's very important. So it's the exit time. So if it's an early contrast washout, the gland versus tumor, it's different. And that's what they try to bank on. Okay.
Yes.
And that sort of creates a gradient where you kind of visualize it differently. So it's not the uptake, it's the early washout or the
Wash.
excretory phase. Okay. So Dr. Vimal, so
Yes.
you'll do a contrast MRI thin slice and all that.
Yes.
Okay. And so if you find a giant pituitary adenoma, say for
Mm.
example in this case involving the sella, suprasellar
Mm.
and parasellar region, extending from the anterior cranial fossa, going behind the clivus,
Mm.
uh, compressing the brainstem as well, and obviously involving the right side cavernous sinus with a okay. What staging? What is the radiological sort of staging that you use for encasement of the carotid? What is it called as?
NOS staging, sir.
Right. So what do you expect in this patient?
Sir, since the cavernous sinus is completely involved on the right side, I would go for a NOS 4.
NOS4. Okay. So if it's a NOS4 tumor extending, like I told, it's a multi-compartmental giant pituitary adenoma. What would be your strategy in these cases? And it's a non-functioning tumor, so you don't have anything to manage medically
So,
to exercise. So how would you approach that patient?
so in this patient, since given the the condition where the patient has got a suprasellar, parasellar, and clival extension compressing over the brainstem, I like to approach it by a combined approach, sir. So transcranial for removing all the clival and the paracellar extension, and endoscopic approach for moving the cellar and the suprasellar, sir.
So in the combined approach, which would you do first? Transcranial
I
or transcranial?
First, I would like to go through transcranial, sir. First.
First, you'd like to go transcranial. Any specific reason for that, Dr. Vartika?
So,
Sir, we would like to try endonasal first
Mm-hmm.
and then proceed with the transcranial if it is required.
Okay. So, and if I'm assuming you're talking about endoscopic, right? Both of you,
Yes,
not
sir. Yes,
microscopic.
sir.
Okay. So, if it's a giant pituitary adenoma invasive going on all the sides, so endoscopic pituitary has sort of transformed that whole concept, and you can go with trans endonasal first. But you need to understand that the vascularity of the tumor comes from the lower part of the dura first, in the cavernous sinus. So Vimal, if you go transcranially first, you are actually likely to encounter much more bleeding
okay,
compared to if you go from below first and then go from above.
right, sir.
Okay, that's one thing. And of course, what is the main advantage of going transcranially first if you are doing it? What is the major dreadful complication with endonasal surgery, which is everyone sweats.
Carotid injury, sir. Carotid artery.
No. It's a
Not
Yes,
question.
sir.
correct.
I don't understand the question. You should take out the lower part of the tumor and leave the upper part.
Mm.
What is likely to happen in the
What,
post-operative?
yeah, what is likely to happen?
That's
Apoplexy.
why that's why your transcranial approach may be of some value first.
Yes.
Apoplexy is likely to happen, sir. Once we take the cellar and supracellar and leave the rest of the portion.
Yeah. So apoplexy, the patient can die from that, as well as once the hypothalamic dysfunction happens, the patient's clinical course and everything, the outcome becomes very severely affected.
Yes, sir.
So doing transcranially first, like Dr. Jha is saying, sir is saying that even it has its own merits, and we all have burned our fingers one way or the other. And
Yes.
so Dr. Vartika, just one thing, if you have to do endonasal and there is a residual tumor where you want to do a second stage from above, what
Yes,
should be
sir.
the ideal time interval for that? How long should you wait?
Sir, we should do it as soon as possible, I think.
Okay. So you have to either way do it in the same setting, if possible, if the blood loss is within acceptable range, or else maximum within 12 hours or so. So I think that's very, very important to prevent any apoplexy in these cases. Jha sir, please, पूछिए sir कुछ और.
So do you have to show anything else? Some
Vartika, you have the images.
है क्या? Okay, I didn't know that.
CT, MRI, anything.
Yes,
Just to
sir. I do have the MRI images.
Yeah,
Go
yeah.
ahead, go ahead.
So that we can complete the discussion, right?
Yeah. I thought it's arbitrary.
नहीं sir. Because
Okay.
good. Yeah.
Differentials, which is in differential भी लिखे हुए थे ना? Okay. ठीक है, Vimal, analyze these images and
So we have more images as well.
Vimal, you can
Yeah.
put out
Can I
these images and
can I
then Dr.
can I go
Vartika
to
can
the,
show
see the
them.
coronal if there is any images, sir? Coronal
Yeah,
images.
yeah. Yes. We have this, and we also have this one.
Yeah. So the MRI is a T1 post contrast image. The current image which is being shown is a T1 post contrast image, which shows a well-defined cellular mass with supracellular extension uh, and invading the right side cavernous sinus and encasing the carotids on the right side completely with partial encasement of the carotids on the left side.
I think it's not encasing the carotid completely.
If not the cavernous sinus itself,
Yeah.
is the cella enlarged?
Yes.
The cella is enlarged, sir.
Sure.
No, cella is not enlarged.
See the sphenoid sinus. Can you see the sphenoid sinus clearly? Sphenoid sinus,
Yes, sir.
not cella. Can you see the sphenoid sinus clearly?
Yes, sir.
Do you see the bulge of the cella in the sphenoid sinus?
Yes, sir.
What happens if there is enlargement of cella?
So there might be thinning of the cellular floor, sir.
So the sphenoid sinus is quite a spacious. So if the cella is enlarged, it encroaches the space in the cavernous sinus. It's more or less. And there is cavernous sinus also, it takes contrast. You have to understand that everything which enhances is not NOS grade 4. Okay.
Yeah.
Right.
So the tumor which NOS 4, you can see the tumor continuity both on all around of the carotid. In any image, it is not all around. Cavernous sinus itself is enhanced. It has gone above the carotid to the paracellular region. Between two carotids in one image. The second one from the left, the lower row.
So this is maximum NOS 3A, not NOS 4.
Okay. It has just gone in between two carotid, that loop. That's all.
Yeah.
So what is this? Pituitary or something else? Or you will stick to pituitary?
We'll stick to pituitary, sir.
Okay.
Dr. Vartika, anything else is your differential here? I mean, what do you think is the primary differential based on this scan?
So primary is the chronic cellular supracellular lesion with extension to right cavernous sinus. Also kept differentials such as tuberculum cell and diaphragmatic cellular meningioma or paracerial cavernous sinus meningioma, craniopharyngoma, or maybe IC aneurysm rarely. So these were all we had kept as initial differentials before the MRI.
So based on the MRI, what do you think is the final diagnosis? Now you have everything, and all the cards are on the deck. What do you think is the final diagnosis?
So non-functioning pituitary macroadenoma with the right cavernous sinus extension.
Why are you still persisting with pituitary? Because like Dr. Jha has said that cella is not dilated. If it's primarily a pituitary pathology, you usually would see a much more widened cella. And you can actually see a radiological sign, classical radiological sign for the air sinuses. Can you tell that what it is?
See the
Next.
sphenoid sinus.
See the sphenoid sinus, see the shape and the pattern of pneumatization.
Sir, it is a cellular kind of sphenoid sinus.
Not just that. There is blistering along with pneumosinus dilatans. It's not significant a lot, but it's definitely the sinus seems to have a little bit wider next to the tumor on the upper part, next to the tuberculum cell area. Okay, so that's typically can happen with the tuberculum cell meningioma or diaphragm cell meningioma, and it can creep into laterally towards the cavernous sinus gradually because these are locally infiltrative pathologies, although benign. That would be our first differential in this.
Because this pituitary tumor, a cellular tumor, before going into the cavernous and or supracellular, will enlarge the cella significantly.
Yes.
Not
Yes.
okay.
You must have operated on this patient by now, right? What
Yes,
did you find?
sir.
What did you find intraoperatively?
So intraoperatively, cellular floor was thinned out, and it was a meningioma,
See, so
pituitary meningioma.
then you can. Why are you still persisting with the pituitary?
Yes. It was a meningioma.
Yeah, I understand that you don't want to get biased with your intraoperative finding, but since now you have the scan, so differentiating a pituitary from this is very important because especially this patient didn't have any hypothyroidism or hypocortisolism sign for 10 years,
So
which was
34-year-old female would have
yeah.
galactorrhea at least.
Yes, yes.
Shock effect.
Shock
Female
effect.
है, young है.
Yeah.
You were not having those findings. So you
No
should have.
menstrual irregularities, nothing. So I think pituitary goes down in the differential. Even Dr. Vimal, that's an important learning lesson for you too. Okay.
Okay.
The idea is for you guys to become wiser at the end of this 2 hours of grilling.
Yes, sir.
That's the only thing. Okay. I think
We can.
yeah, Dr. Harsh, we
the
can.
Yes, yes, sir. We can shift to the second one. Dr. Vimal, you can start your presentation. Yeah.
Yes, we can see your screen, Dr. Vimal.
So I'm presenting a 45 years male from Bangladesh, farmer by occupation. History was told by self and was reliable. Presented with the complaints of progressive weakness and tightness of both upper and the lower limb since the past 9 months. He also complains of paresthesias of the bilateral upper limb since the past 6 months, with increased frequency of urination since the past 6 months. So the weakness was insidious in onset, progressively worsening, and involved both weakness and tightness of both upper and the lower limbs since the past 9 months. He began to notice 9 months back when he was not able to keep up with his peers. Initially, it began as a difficulty in wearing slippers, with frequent slipping of slippers, which later progressed to difficulty in getting up from chair. The weakness was asymmetrical in distribution, with distal to proximal in progression. The weakness of the upper limb progressed as difficulty in holding pen, buttoning shirts, and breaking chapatis, which progressed to a difficulty in reaching out for objects. There was no history of difficulty in getting up from bed without support or turning side to sides in bed. There was no history of increased difficulty in walking in dark compared to walking in light. There was no history of feeling of walking over cotton-filled sensations or over a layer of air. The next history was paresthesias of the bilateral upper limbs, which was there for almost 6 months. It was insidious in onset, progressively worsening numbness and tingling sensations along the upper outer aspect of bilateral upper limbs. He was able to appreciate the presence of bed sheets or clothes all over the body and was able to appreciate mosquito bites. He was able to differentiate between hot and cold water. There was no history of unknown injuries over the limbs without notice. He also complains of numbness and tingling sensation in bilateral lower limbs. There was increased frequency of micturition since the past 6 months. There was no history of urinary hesitancy or difficulty in initiating micturition. He also complained of increased urinary urgency with incontinence. There was no history of reduced urine outflow, frequent dribbling of urine, or incomplete evacuation. There was no history of recurrent UTI. Negative history. There was no history of reduced sensations over the face.
Okay, Vimal, can you stop for some time?
Yes.
Okay, Vartika, based on the okay, go back to the chief complaint slides. So just based on that, Vartika, what do you think is the primary differential? Not differential, I would say, where would you like to localize, and what sort of history are we going towards?
So since there is both upper limb and lower limb involvement with spasticity and urinary complaints, we'll try to localize it in the cervical region since both upper and lower limbs are involved.
Okay. So based on the duration of the history, would you and the presentation symptoms, just based on the chief complaint, do you think it is a extradural pathology or an intradural pathology? And if it's
So,
intradural, then IDEM or intramedullary?
so it looks like a intradural pathology, and it looks like an intramedullary pathology as well.
Okay, why would you say that?
So there is no complaint of pain right now. If it was an extradural pathology, pain would have been present. And then there is spasticity, there is early involvement of
What are the
urinary.
what are the
the
three
age of the patient? Age क्या है? What is the age of the patient? Age.
45.
45.
Okay, go ahead.
So what are the three cardinal symptoms of an extradural pathology? Pain is one, you are right. What are the other two?
So pain, then early involvement of lower limb followed by upper limb, like the ascending complaints. And also radiculopathy might be there.
Okay, so I mean, the pain, tenderness, and deformity. These are the three things that you need to look for, especially in extradural pathology. That's one thing. Apart from that, do you think the urinary involvement is an early history of urinary involvement here? Is there bladder involvement or not? Based on just the
Since
history.
so
Go back to
based on
the page.
So based on history, the first complaint started like 9 months back, and there is already the involvement of increased frequency of urination since last 6 months. So it is comparatively earlier involvement.
Early. So early involvement happens in which pathology?
Sequence.
So then it should be extramedullary and extradural.
No. Early
Early
involvement
bladder
happens.
involvement is
Sorry,
suggestive
early
of what?
involvement is intramedullary.
Okay.
Yeah.
What is here? It is late or early?
So this is early.
What do you mean by early?
Oh.
Whole symptom started from 9 months. The last symptom was bladder symptom.
Sir, it's a short history.
Okay. 9 months is short history. Okay.
Yes, sir. That's why early involvement.
That is not called early. Early is the first, second, third, fourth symptom. Okay, there is a sequence of symptoms. So in sequence of symptoms, where the bladder symptoms are placed, that is early or late. Okay.
In that case, sir, this is late.
Go ahead.
For negative history, there was no history of reduced sensations over the face along the V1, V2 dermatome, and there was no wasting of the facial muscles. There was no history of difficulty in breathing. There was no history of difficulty in swallowing, nasal registration of food, or hoarseness of voice. There was no history of neck pain or back pain or radicular pain along the upper and the lower limbs. There was no history of thinning of limbs or flattening of shoulders or thinning of palms. There was no history of twitching of any muscles. There was no history of trauma. There was no history of imbalance while washing face in the morning. Past history, he is not a known case of diabetes, hypertension, tuberculosis, ischemic heart disease, or cerebrovascular accident. There was no history of any surgeries in the past. Family history is not significant. Personal history.
We will go back to the previous slide.
Yes, sir.
The one before it. Yeah. So based on the negative history, can you analyze each symptom and tell how is it relevant to sort of localize it horizontally or vertically, and what does it make sense? Vartika, questions directed to you.
Sir, there is reduced sensation over the face that rules out involvement of trigeminal nerve. There is no history of difficulty.
So if there was involvement of trigeminal symptoms was there, then what would how would that change your vertical level of your localization, I would
So
say?
we would have thought of a pathology in the brainstem as well, not just the cervical region.
Okay, what is this lowest level of the spinal nucleus of trigeminal? Where does it
So
go to?
C3.
C3. Okay, so since there is now no history of that, so how would you say that where your location or localization of the lesion is? That means it is below.
So between C3 to C7.
C3.
So below C3 and above D1.
Above
D1.
D1.
D1. That's
but upper limbs are involved, na?
Yeah.
Yes, sir. That's above D1.
D1.
Yes, sir. Like thoracic, above thoracic.
Yeah.
And below C3.
No, upper limbs are involved. So
Yes,
upper
sir.
limbs are involved, especially if the proximal muscles are also involved. That would mean that the lesion is above that level. And
Yes,
since the trigeminal nucleus is not involved, so it means it is below a certain level, that is below C3.
C3, yes.
Now, would you like to rephrase the answer, like Dr. Jha is pointing out?
Above what?
Above what?
Sure, sir, the pathology should be below C3 and above C5.
Yeah. Okay,
Yeah.
so that's how it's like a way of sort of analyzing your symptoms. And in spine, I think the history and examination adds a lot of localization value to it, because you will find different pathologies, multiple pathologies, and which one to address will be based on a history and examination. Okay. Okay. The next symptom, can you read?
So there was no history of difficulty in breathing. So we are analyzing phrenic nerve here, which can involve level till C4. So we are also ruling out the level C3 and C4.
So phrenic nerve is only C4? What is the root value of phrenic nerve?
So C3, C4.
Just C3, C4? Is that so?
Oh,
Dr. Vimal, would you like to add?
Yes, so C3, 4, and 5, sir.
Yeah, so C3, 4, and 5.
right.
Okay, so that's something that you need to know. Okay, what about the next symptom?
So there was no history of difficulty in swallowing or nasal regurgitation of food or hoarseness of voice. So basically, we are ruling out the lower cranial lobes.
Yeah, okay.
Then there was no history of neck pain or back pain or radicular pain along the upper and lower limbs. So we can rule out the extradural pathologies because they should present with one of the pains.
Right, fair enough. Okay.
And there was no history of thinning of limbs or flattening of shoulders. So we are ruling out the atrophy. And there is no history of twitching fasciculations. So we are also again ruling out the lower motor neuron signs. There was no history of trauma, no history of imbalance while washing the face in the morning. So we are ruling out the dorsal column involvement in this.
What is this ataxia called as if it is present?
Sensory ataxia.
No, I mean, it's called
The motor ataxia.
wash basin
The
ataxia.
Romberg sign. Yeah.
And the Romberg sign is similar, but it's not the same. This is during washing phase, you have imbalance. This is again proprioceptive issues. Okay. So based on, okay, please proceed. I think we can take up the further localization later.
So past history is not significant. Family history, there are no history of similar complaints as a family. Personal history, appetite normal, mixed diet, bowel habits were normal, sleep was undisturbed. So 45-year-old male presented with 9 months of progressive weakness of upper and lower limbs, which indicates involvement of the anterior and lateral corticospinal tract with numbness and paresthesias of the limbs with cottonal sensation, suggesting dorsal column involvement. Over the past 6 months, the patient has developed urinary disturbances, indicating involvement of the autonomic nervous system. There is asymmetrical spastic quadriparesis with functional status being Neuri grade 3.
Okay, so Vartika, how do you analyze the urinary symptom? Is it a spastic bladder? Is it a flaccid bladder? How
So
would
it
you?
is a spastic bladder. Since there is urge incontinency increased in the frequency of urine, and so it should be spastic. Let me
Yeah,
see
go to that. Okay, so now you can.
There is increased urinary urgency, incontinency, and also frequency, which are the symptoms of a spastic reflex bladder.
Okay, but there is no history of any urinary hesitancy or difficulty in initiation of micturition also, right?
Yes, sir.
Okay. And okay, so in the flaccid bladder, what all symptoms do you think the patient has?
So we usually have urinary retention and hesitancy, and there is reduced urinary flow.
Okay.
Basically, the storage symptoms are present.
So it's basically incomplete evacuation of bladder is there, and then the patient keeps on dribbling urine off and on.
Yes.
Okay, that's a very typical history that the patients give. Okay, so go back to the summary, Dr. Vimal. So analyze each aspect in the summary and then localize the lesion vertically and horizontally within the spinal canal.
So there is progressive weakness of upper limb and lower limb. Sir, but it was not mentioned which came first. Like, was it lower limbs first or upper limbs first?
Right. So that's a pertinent question. And Vimal, would you like to answer to that?
So patient developed weakness of the upper limbs first, followed by
Which upper
involvement
limb?
of right upper limb, sir.
Right upper limb.
Right upper limb,
Then
followed by weakness of the left upper limb, and followed by the asymmetrical weakness of bilateral lower limbs, in which right came first, followed by left. Patient started noticing on the right side first.
No, so
Vartika, what do you interpret now?
Sir, it was not mentioned earlier whether it was symmetrical.
Now he has explained it now.
Sir, since it is a descending kind of weakness, so, because upper limbs came first, followed by the lower limbs, so it is descending in nature, which again points towards the intramedullary lesion, maybe.
Okay, go ahead.
Indicating the involvement of anterior and lateral corticospinal tract. So to analyze the involvement of anterior corticospinal tract, we also need the history, such as was the patient able to get up from the bed, or could he turn side by side, like without support? That was missing, I think. So we do not know if anterior spinothalamic tracts were involved or not.
Vimal,
Also,
can you answer that?
Sensory disturbances, patient had numbness and tingling sensation, but there was no specific sensory disturbances the patient had because
No. Truncal weakness. He's asking
I
about.
have mentioned, sir, the patient was able to get up from bed without support and he was able to turn side to sides.
Okay.
so that means there is no anterior spinothalamic tract which was involved.
Spinothalamic.
Not spinothalamic, corticospinal or spinothalamic? What are you saying?
Oh, sorry, sir, corticospinal.
Okay.
Also, sir, he has written there is no history of feeling of walking over the soft cotton surface. And later in the history, he has said that there is dorsal column involvement. So that's a discrepancy, I think.
Yeah. So the
Also,
cotton wool sensation. Yeah, exactly. So cotton wool sensation, Vimal, why have you written that?
No, with the cotton, I mean, there was no history of cottonal sensation, sir.
but he has mentioned dorsal column
Limbs with
involvement.
cortical sensation. ये लिखा हुआ है ना?
Sir?
Summary. You have written in the third line, perhaps.
Yes, sir.
Numbness
Patient had history of cottonal sensation, sir.
Indicating involvement of anterior and lateral corticospinal tract with numbness and paresthesia of the limbs with cotton wool sensation. So, do you stick to that, or there is typographical error?
It's a typographical error. Patient had a history of cottonal sensation, sir.
No. He had a history of cotton wool
He
sensation.
had history of cottonal sensations.
Okay. So now you have involved posterior column also.
Yeah.
Okay.
Were there any skip lesions, Vimal, in the history?
Sir?
Were there any skip lesions or, that abnormal sensation in the body, paresthesia, which is like at a certain dermatome it was there, and then they were skipped,
No, sir. Nothing
and
like
then,
that.
then it was there, something like that. Because I think that history is also incomplete as far as, detailed understanding of in the whole picture is there.
Okay.
Sir, in this history, he has mentioned he was able to appreciate the presence of bed sheets and clothes, which says that the crude touch was present. And then he was also differentiate between hot and cold water, which means temperature was intact. And there is no history of any injuries over the limbs without notice. So pain was also present. So where was the numbness and tingling sensation which is present? And in last line, tingling sensation in all limb, like which dermatome was involved. That is also.
It was not specific to any dermatome, sir. It was like generalized numbness and tingling he had all over the limbs.
But then again, you have mentioned upper and outer aspect of bilateral upper limbs.
It was in the upper limbs, but bilaterally on the lower limbs he had in all dermatomes involved.
Okay.
Yeah,
And
so basically in the history, you need to be a little more circumspect about these things, Vimal. So just to give a complete picture. Yeah, go ahead, Vartika.
so also outer aspect of like what? Forearm, arm, or like hand. That is also
Entire
missing.
limb.
What?
Involving all dermatomes of the upper limb, actually.
Okay, all like forearm, arm, and hand,
Yes.
all three were involved.
Yes.
Okay.
So, Vartika, based on just this second line in the paresthesias part, that insidious onset progressively worsening numbness and tingling along the upper and outer aspect of bilateral upper limb. Is there any specific pathology that comes into your mind which presents
So
with
it involves C5, C6, and C7, like
No.
all three
Any,
levels.
no?
any specific pathology which usually presents like this, commonly in the country?
Which probably Dr. Vimal is trying to emphasize here based on what he has written. So think about it, just imagine a person with this kind of sort of presentation of symptoms on the outer aspect of upper limbs, both the sides. What comes into your mind? Okay, Vimal, can you?
There are intramedullary pathology, like
No,
such
that
as ependymoma.
which disease usually presents like
Yeah.
this in our country, in our OPD?
Yeah.
So syringomyelia usually
Yeah.
comes like
Yeah.
that.
So I think someone just wrote it on the text
Oh, okay.
on the dashboard. Yeah, but I think it's the perfect timing for you. So yeah, so syrinx, right? So I think maybe Dr. Vimal is trying to bring out that part of the history. So whatever is written in positive is also you have to understand and analyze each symptom on its own merit. And then you find out what negative history is relevant uh, to sort of further differentiate ki ab kya hai. It's like you must have seen some online, that OTT shows and all that, right? Medical dilemmas and all that is there. Ki acha ab diagnosis kya hai. So you're trying to sort of fish out the diagnosis based on your history and your examination. So that's the whole idea.
Okay,
I
sir.
think we can proceed.
Sir, if I may, is there any eye signs would you want to ask in this specific case,
Yeah.
which is completely missed by both of you actually?
Horner
Some
syndrome.
eye signs or some skin changes or something, since you're harping on intramedullary quite a lot.
Features of Horner syndrome.
Yeah, so why weren't they mentioned, man? It's okay, chalo, go ahead.
Go ahead, Vimal.
Yes, sir. On general examination, he was conscious, oriented to time, place, and person, vital was stable. Height was 158 centimeters, weight was 63 kgs, and with a BMI of 25.2. There were no neurocutaneous markers. Systemic examination was normal. The single breath count was 26, with chest expansion of 4 centimeters. His neck height ratio was 1:13. There was no downbeating nystagmus, low lying hyaline, or torticollis, or short neck. Neurologic examination, his higher mental function was intact. Cranial nerve examination, sensations were intact in all dermatomes on either side of the face. There was no temporalis or masseter wasting with no deviation of angle of jaw. The uvula was central and gag was present bilaterally. Shrugging of shoulders and sternocleidomastoid functions were normal. There was no evidence of Horner syndrome. There was no wasting of the muscles in the upper and the lower limbs. Tone was spastic in all 4 limbs. The power on the upper limbs, the upper and the lower limbs were as follows. Power was grade 5 in shoulder flexion extension, and grade 4 in elbow flexion extension, and a grade 4 in wrist flexion extension with a poor hand grip bilaterally. He had grade 5 power in bilateral lower limbs. Sensations to touch, pain, and temperature were reduced by 30% on both sides below the C5 dermatome. Vibration proprioception was normal. Joint position sense was impaired in bilateral ankle and toes. Perianal sensations were preserved and anal tone was normal. Deep tendon reflexes were exaggerated in bilateral upper lower limbs except for the right biceps here. Superficial abdominal reflexes were absent. Hoffmann-Tromner's was positive bilaterally. Plantars were extensive bilaterally. Rombox was negative and there were no signs of cerebellar dysfunction. There were no midline tenderness on palpation of spine. Gait was spastic and unaided. Summary: this 45 years male presented with a progressive worsening, tingling and paresthesia and weakness of bilateral upper and lower limbs with associated bladder disturbances. On examination, he had spastic tone of all limbs with weak hand grip and exaggerated deep tendon reflexes with positive Hoffman's and a spastic gait.
So, Vartika, how would you analyze it?
Sir, since Hoffman's is positive, the pathology should lie above C5. And also, he had spasticity of all limbs with a weak hand grip and exaggerated DTRs. Again, it should be above C5, and there should be involvement of corticospinal tract. And there was progressive worsening of tingling paresthesia. The sensory column is involved. And
Motor involvement, what was the highest level of the motor involvement?
sir, he has said weakness of upper limb and lower limb, but the power was 5/5 in all
So
lower
it was
limb,
4
right?
by 5 for the elbow flexion, okay? And the
Yes, sir.
shoulder, it was 5 by 5.
So it
So,
should be below C4, around C5,
yeah,
elbow flexion.
What
yeah.
was the biceps jerk, Bimal?
The biceps jerk was diminished, sir.
Diminished.
Yes, sir.
C5 again.
Okay. And triceps was exaggerated.
Yes, sir.
Okay.
Mhm.
And the highest sensory level was?
C5, sir. Below C5, all responses, sensations were diminished.
Vartika?
Sir, all the response was reduced by 30% below C5.
No. What do you interpret by diminished biceps jerk and
Sir,
all other lower down jerks were exaggerated?
sir, decreased bicep jerk means that the pathology is present at that level. And for all the other jerks, it is a upper motor neuron type of pathology. So that's why they were exaggerated.
Okay.
So the level should lie around C5.
What about the pectoral jerk, Vimal?
Patellar jerk was normal, sir.
Was normal. So because you said all the details were exaggerated except for biceps.
Yes, sir.
Because pectoral has to be normal if the pathology is below that C4 and almost at C5. This
Yes, sir.
okay, because the biceps is diminished. So you can always revisit your examination if you find something which is odd, and then even in the history you can go back and
Yes.
read things. Okay.
Anything else you want to add, Vimal? This was the last example. Anything else in the example? No.
No, sir.
So it's now your final interpretation, Vartika. Diagnosis.
It should be an intramedullary pathology at the level of C5.
C5. What is that pathology? Likely.
Sir, it can be an intramedullary tumor.
Which tumor?
It can be ependymoma or an astrocytoma.
Ependymoma from where to where, or astrocytoma from where to where?
Sir, ependymoma from C4 to C6, and astrocytoma might be along C5.
So if you have a fairly large intramedullary lesion, would you expect some wasting or not?
We would, sir.
Yeah, but there was no wasting as per the history and the examination so far, right?
Yes, sir.
So that's another little odd part. And with a weak hand grip, particularly, how would you attribute to that? So hand grip is which myotome primarily?
The
Vartika?
C8.
Just C8 or something else?
C81.
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 Right. So what pathology? I mean, so the pathology, does it have to go all the way there, or something else can happen with the pathology which is higher up and still there can be hand weakness? You understand my question?
No, sir. Can you please repeat it?
Okay, so say for example, you have a pathology, you have a CVJ pathology, not in this case,
Yes,
but
sir.
I'm just saying a CVJ pathology. Patient with CVJ comes with wasting of your hand muscles and hand
Yes,
grip
sir.
weakness. How would you attribute that finding in that patient?
Sir, because of the venous congestion,
Yeah.
this can happen.
So what happens with the venous congestion?
Sir,
C8 even how these two will get involved.
Sir, because of the venous flow, it is from caudally to cranially. So if there is a compressive myelopathy and if there is a
Why at
venous
C8 D1? You are right. Why at C8 D1?
D1, yeah.
Watershed areas of the spinal cord.
Sorry?
The watershed areas of the spinal cord.
watershed area is present in at this point.
No, both of you are wrong.
Okay.
So the anterior horn cells are very sensitive in this area to the venous congestion with the C81. Okay. So because of the venous hypertension, they can get atrophied and that leads to weakness. Okay.
Yes.
So that's one of the postulated hypothesis. There is no specific exact reason that they have found out, but that's the most acceptable theory. Okay, and okay, now coming back to this particular patient, still this patient has hand grip weakness with a pathology close to C5 or C4 to C6, but like you're saying, how you can have a hand grip weakness and numbness along both the shoulders. So what kind of pathology and associated something is there? We already discussed that. Vartika,
Syringomyelia.
yeah, syringomyelia. So
Yes.
which particular neoplastic pathology are notorious to cause syringomyelia in spine?
Ependymoma or
Epidermolysis.
Ependymomas.
Anything apart from these two? Anything else which can cause huge syrinx even with a tiny lesion?
Highly vascular.
Yes.
Hemangioblastomas.
Yeah. Okay. So you have to keep these differentials. Even a small C5 hemangioblastoma which can lead to just biceps jerk diminution, can have a syrinx which extends down and cause this weakness, this numbness, which is not explained by other things. Okay. And that's why there is even the lesion. What is the location of the hemangioblastomas?
Sir, it lies closer to the dura.
Dura means what?
What I
Sir,
mean,
because the blood supply is coming
Arachnoid,
from the
tracts, gray matter, what?
sir, it should be closer to the white matter because the blood supply of the dura is coming from there. So the hemangioblastoma will form around the vascular supply of the
Usually पायल होता है, पाया पाया.
pia. Sorry, sir. Pia.
subpile. The lesion is subpile.
Yes, sir.
Despite being subpile, the syrinx is intramedullary purely, right?
Intramedullary. Yes, sir.
Right, it's in the center. So even the lesion is subpile, it can still have a large intramedullary syrinx, which can lead to many of these symptoms.
Yes, sir.
Understand? So you have to analyze in a very unbiased manner.
Yes, sir.
Okay. Dr. Vimal, would you like to add something to it? To the differentials or anything, since you've worked up this case?
Yes, sir. We thought the same case to be an intramedullary lesion, but unfortunately, imagings were suggestive of an intradural extramedullary lesion.
Okay, so we can.
Right? Show the images.
Yeah, show the images, and then Dr. Vartika can. Okay.
Can you please enlarge it? So we can see this is a T1 weighted sagittal image of the cervical region.
So images. Vimal.
Sure.
What do you mean by a lesion?
Yeah.
Sir?
What do you mean by a lesion? Lesion means what? If there is myelopathy or intensity changes, is that a lesion? Or it is not a lesion?
No, I can't get you, sir.
Vimal, what is the difference between lesion and neoplasm, man?
So there is a surrounding mass effect.
No. What sir is trying to say is lesion is very non-specific. Even myelomalicias, edemas, everything can be
Okay.
If
classified
there
as
is
a
edema,
lesion.
that is also a lesion.
Everything is a lesion. So when you're classifying these things, you say it is a neoplasm or
Only the tract, corticospinal tract or posterior column doesn't differentiate between edema and tumor. If it is compressed by an edema or a astrocytoma, it behaves similarly. So there is intramedullary lesion in the form of edema. There is hyperintensity within the cornea.
Yes, sir.
So that has been caused by outside
Edema.
compression, but due to that, there is a lesion within the cord which is caused by that edema. Got my point?
Yes.
So that is also a lesion. If there is intensity change, myelopathy, there is myelopathy.
Yes, sir.
Accept, na?
Yes, sir. There is myelopathy.
That is a lesion. It has been caused by something outside the dura, but it is also a lesion. Okay, so
Yes,
go
sir.
ahead. Show the images. So Vartika, analyze the images. Tell
So
about
this is a T1 weighted sagittal section of the cervical.
T1.
The
T1 or something else?
There's no T1.
Sorry, T2. So sorry. It
Those
is a
are-
T2 sagittal image of the cervical section. We can see there is a 2, 3, 4, 5, 6. There is a disc bulge at C6-7 level along with the cord changes, which can be seen in the form of the hyperintensity, which is present along the C6 and C7 level. Also in the axial sections below, so the same intensity is present in the as the mirror image, and it is present in the intramedullary
What is the age of the
region.
patient?
45 years, so.
Is that the disc that is anterior to the cord?
Sir, it can be a ossified
yeah.
posterior longitudinal ligament as well.
Those two things are different, na?
Yes, sir.
Anything else?
Yes, sir, along the C6-7 level, posteriorly, we can also see ligamentum flavum hypertrophy.
Okay. And
And
What about the curvature of the spine? Anything?
so there is straightening, there is loss of lordosis of the cervical spine in this.
Right.
what is in the axial?
So we can see there is hyperintensity which is present in the intramedullary region. It is present as two white colored hyperintense dots which are like mirror images of each other. It is present in the third image, sir, on the right side.
So what does that signify and what is that sign called as?
Sir, it can be called edema. It signifies called edema.
It's the degeneration of the, and again, the gray matter, the anterior horn cells. Okay, so it's called snake eye sign.
Cobra eye sign.
Yeah. Okay. You have other images, right? And some X-rays or something also,
Yes,
I
sir.
think, to show that. I think we have to, yeah, reduce the zoom. Okay. Based on this X-ray, Vartika, you want to comment some things? Just the
Sir,
X-ray. Read the X-ray well.
Sir, this is the X-ray of the cervical region. We can see there is straightening in the curvature of the spine, and we can also see the formation of anterior osteophytes at 5, 6 level.
Not just 5, 6, 6, 7 also.
Yes, sir. Anterior osteophytes can also be seen.
What else?
Anything else?
So there is reduced in the interdiscal height between
Disc height.
disc height.
Disc height.
Yeah.
Yes, sir. It is reduced in C5, 6 and 6, 7.
Okay. Anything else which is appreciable here?
Can you please zoom it a little? So there is a ossification which is also seen of the posterior longitudinal ligament from C3 to C6.
There seems to be maybe a segmental OPL or something.
Yeah.
And what about the facets? Can you read what's happening to the facet?
4. So at 4, 5 level, there is decreased facetal height, I think. So there is no locking though. The
Yeah, of course,
facets
there
are
is
not
no
locked.
listhesis. There is no listhesis. But
Yes.
what is this phenomena? Okay, compare the density which you see in the facet of C2-3 versus C3-4 and C5-6 or 6-7. Can you see the difference? Look at the
Yes, sir.
C2-3.
The
So,
density in the 2-3 is less as compared to the lower vertebrae.
so basically, it's called vacuum phenomena, which happens when degenerative
Yes.
spine changes. Okay, even you see more in this lumbar spine with the disc where there is a vacuum phenomena. That's actually, people say that it's a sign of instability, which is bound to happen later on. But at least it's a sign of advanced degeneration, which for the age it's much more than expected.
Yes,
So
sir.
Vimal, now can you say that did you miss anything in the evaluation of the patient clinically, which could have hinted at the degenerative cervical spine disease? What else you could have done so that you could have identified that maybe something related to degeneration is there? Vimal,
Yes, sir.
in your examination,
Yeah.
did you miss something? You said that there is no pain, no tenderness. Okay.
Yes, sir.
Any movement restriction or movement pain?
Uh,
And what is the job? What is the job of the patient?
he's a farmer, sir.
Okay. Does he carry heavy weight over his head?
There was no significant history, sir, but he might have.
Huh? No significant history. So
Yes.
any neck pain, neck restriction, all. What was the movement? Neck movements.
Flexion, extension.
No, flexion, extension. 6 movements are there. No?
Yes.
Flexion, extension, tilting right, left, and rotation right, left. So what was the range of movements? Was there any pain or restriction? So these things you could have seen.
Farmers usually have a very heavy
Hard.
lifestyle, and they're very, very physically active, lifting weights and other things on the
Could
heavy.
have found something, or have you operated all of the patient, or still
We
the
have
patient
operated, sir.
operated?
Yes, sir.
So you should have seen these things also. So cervical examination includes, unless until you have some strong clinical suspicion there is instability, otherwise you have to examine these things also. Okay?
Yes.
And
So
pain would be there to some extent in this patient. Very unlikely
or
that
neck restriction,
lordosis.
neck restriction or pain at some extreme of the neck movement. That would
Yeah.
have helped us to identify the mm, mm, disease earlier. Okay.
Yes.
Okay. So what you will do?
What?
What do you do in such cases? Okay, this is the CT.
There again in this we can see there is formation of anterior osteophytes which is present.
Not just anterior, I think there are posterior
Posterior also is
Yeah.
at 5 and 6. Posterior osteophytes are also present.
5, 6, 6, 7.
Yes, sir.
Okay, so how would you proceed in this, Dr. Vartika?
Sir, we can also get dynamic imaging of the cervical X-rays so that we can determine if there is any instability and if there is a need for fixation in the patient or not, which will help in our surgical planning. After getting the dynamic X-rays, we can proceed with the surgery. Mm.
Surgical procedure, what do you think would be helpful for this patient?
Sir, I think anterior cervical discectomy would be help.
Put
ACDF
the
would be.
Vimal, put the MRI again. Put the MRI Sag T2. Yeah. Now tell.
बस डिस्क तो नहीं है ना? Is there disc that is black?
Sir, we'll use K line to determine. Since in this K line looks to be positive, we can also proceed with the posterior decompression of the cervical region.
Posterior I mean, what are the factors that would advise you to go posteriorly?
Sir, while assessing the OPLLs while drawing the K line, if it is positive, that means it would be beneficial if we proceed from the posterior decompression instead of an anterior one.
What are the things you're trying to achieve in this patient?
So
What is the
first,
aim of the surgery?
so since cord edema is present, so we want to decompress we want to give the space so that
So the maximum compression is anteriorly or posteriorly?
so it is anteriorly.
So then why would you want to address posteriorly in a patient who is fairly young,
Yes, sir.
right?
We can proceed with sir C6 corpectomy with ACDF.
ACDF, okay, or ACCF.
So ACCF would be more helpful in this.
Yeah, because in the MRI you can see even at the behind the body of C6 there seems to be some compression. Might not be significant, and there is some C5-6 degenerative changes also. And the
Yes, sir.
patient is already has a lot of myelopathy. You may get away with a ACDF of just C6-7, but you may require a little bigger procedure. And I think that's a decision which has to be taken by the operating team.
Yes, sir.
So we did a C6 corpectomy and fusion with
Okay.
IBG for this patient. So
Okay.
because like there was posterior osteophytes on both the inferior surface of C5 and the inferior aspect of C6 also. So we wanted to do a C6 corpectomy, and intraoperatively patient had thickened OPLL
Yeah.
with posterior osteophytes.
Right.
So we did a corpectomy and fusion with IBG.
Yeah. So, and even with the ventral procedure, you can actually address the kyphosis, which is sort of
Yes, sir. That was the main aim of the surgery,
so the
was
idea
to
is
achieve the curvature of the spine and
absolutely,
to
yeah.
relieve the cord compression.
So, I mean, if there would have not been a thickened PLL, I would have said maybe just do
Yeah.
level disc or maybe two-level disc just to
Yes, sir.
jack
We
up
had an oscillation of
and get the yeah.
T67 anti-cervical discectomy and putting a bone chiclet inside. But
Yeah.
since there was changes behind the bone also, we wanted to proceed with the corpectomy.
Yeah. Especially in edematous cord, I think there's very unforgiving cords.
Yeah.
If you just do minor decompression and you don't decompress it adequately while manipulating it, putting the traction and everything, putting vertebral artery spreaders, they can actually cause more trauma to the patient, and patient can have worse quadriplegia
Yes.
after the surgery. So you need to sort of address these very carefully. Okay.
Okay.
I think,
We are done.
I think so we can proceed to the OSCEs.
Yeah.
Dr. Harsh?
Vimal,
Yeah.
can you unshare your
Yes, sir.
screen, please? Yeah. Oh, yeah. So, I think probably one of you can start. So, obviously, sir, you can change the questions as and when you like. This is the MRI image of a patient that we recently had. What do you think is the diagnosis of this case? Be very careful when you're seeing the image.
Can we go back, sir?
Yeah, sure. Why not? Carefully.
Vimal and Vartika.
Right CP angle.
Right CP angle lesion.
So that is why these things should not be. And if it was a CP angle lesion, do you think I would have placed this here?
The CP angle
Right.
means what? Rising from which nerve?
If I have placed this here, I must have thought
Caustic
of
or
something,
something
right?
else?
Think very, very carefully. If you want some other images, I can show you
Yes.
other images also. Chalo, I'll show you. You
Yes,
should
sir.
have asked for these. Now look at these images.
The caustic or something else?
What do you think this is? See very, very carefully. I'll stop at that image also.
Now
Do
you
you
can,
still think? Do you still think it is a CP angle lesion or a
Right.
caustic, as you want to call it?
what structure is this, Vimal? Which Dr. Harsh is pointing out?
See, I'll stop at particular images. Now, please be very, very careful when you're answering.
Which foramen is that? Where the
Jugular
lesion
foramen.
is visible in MRI? And which foramen is visible in the CT? These two are different foramina. Which one is in the MRI? Which one is in the CT?
Jugular foramen in the MRI and the IAC in the CT, sir.
So then it is not a CP angle lesion, right?
Yeah. So
It's
what
a
else
lower,
can it be, Vartika? Or
What is the diagnosis now? See,
it's a
that
lower
is why I
cranial
placed
trauma.
this specific image for you guys. So, okay.
It's a lower cranial schwannoma, sir.
Jugular fossa.
Fine. So, what is the present? What would be the possible presentation of these patients when they come?
Hoarseness of voice, dysphagia, and nasal regurgitation.
Do you think with a single vocal cord or vagal nerve or the ninth nerve, this much presentation will be there?
No, sir. The patient would have got used to do it if there is a long-standing
Yeah.
history.
So, Vimal, think and answer. Think and answer. Don't be in a hurry. What is the possible presentation?
Hoarseness of the voice could be the presentation, sir.
And
Nasal trangling of voice.
Dysphagia, sir.
this patient presented with recurrent pneumonias actually. Fine. So what would be your approach? What outcomes are you looking at on how would you counsel these patients?
So, patient might, I mean, we would go with retromastoid suboccipital craniotomy excision of the lesion. So, the patient has higher chances of complete damage of 9, 10, 11. So, there is post-operatively, patient might be on NG tube for a long time and he might go in for tracheostomy. Post-op ventilation will be, prolonged ventilation will be there.
you want to do a typical retrosig approach or a modification
Something
of?
else, yeah. Something you want to add to that?
You can see the CT scan also.
It's okay. Retrosig is fine, but some extra step you have to do
Yeah.
specifically for this extension.
Retrosig you do for in IAC, lesion at IAC. What do you do for lesion at the jugular foramen? In addition to RMS, retromastoid.
Something you will drill extra, remove extra.
Will go down, na? Down to which structure?
It's not vertebral artery, I'll give you a hint. Something else you want to do.
Vartika, anything else you want to add?
Occipital condyles.
Mhm. Yeah. So what is that approach called?
Far lateral approach.
Yeah. So basically, you have to remove the magnum in these cases. Definitely, when you're doing definite removal of magnum is needed.
And then you can maybe just tailor your resection of the condyle depending
Yeah.
upon the pathology, because many times the pathology itself is big enough, it creates space. But if the pathology is small, then actually you need to do a lot more bone work to really prevent any traction injury to the vital structures of a brain and nerves.
Okay. So this is another case. What do you think is the differential diagnosis in this case? This is a 2-year-old child. And be careful, I have put this specifically for a reason. Do not jump at the diagnosis. If you want some
Sir,
other, I'll show you the other images also.
Can so it
What image is
can be
this?
a medulloblastoma,
See, that is why. No.
Medulloblastoma.
Why do you think I would have placed a
DTI.
medulloblastoma in this? Is there a specific reason why will I place a medulloblastoma in this situation? Do you think it is fourth ventricular or is it involving something else? Have you seen a medulloblastoma extending up to the thalamus?
Diffuse midline glioma.
No, sir.
So then think there's
This
no
spotter.
urgency.
This is a spotter.
Could be a diffuse midline glioma, sir.
Yeah, again.
Yeah.
Or socho, ठीक है, diffuse midline glioma, is it diffuse? I've shown you a DTI image also. Do you think it is diffuse? Are the tracks going through the lesion?
No,
No,
sir.
sir.
So then think it is something which is related to the newer classification. I'll give you that much.
The embryonal tumors can be present.
Already someone has written it.
Good. Chalo, at least somebody knows. So
Yeah,
what
I
is this?
Full form.
What
Tumor.
is this? Yeah, you guys are. So what does the color coding stand for in the DTI? What is red, green, and blue?
So these are the 3 type of fibers: projection fibers, association fibers, and
See,
so
at your
the
level, I expect you to answer red is this, blue is this, and green is this.
Which particular tract? That's what he's asking.
so it represents corticospinal tract,
What
and
represents corticospinal tract?
and the fibers are the
Which color represents corticospinal? Which color represents association? Which color represents projection? This is an exit exam.
Yeah.
Sir,
Very straightforward.
blue represents the projection fibers and green the association.
Projection.
See, if you
So
see the
blue is
image, you will be able to answer. It is in the image. The answer is in the image.
So blue is the projection fiber, green is the association fiber, and the red one is the corticospinal.
How can the corticospinal tract
What
be
is the
at this
color of the
level?
sky?
In callosal, do you find corticospinal tract? See,
No,
I have
sir.
put supratentorial images in this image only, specifically for this reason, that you see the supratentorial image and answer. What is this image? I'll show you this image.
Yeah, just go to the corpus callosum, I think. Then they will understand. Yeah,
So
this
yeah, it is.
थोड़ा और पीछे और
Yeah, sorry.
here.
So this is callosal fibers. Yeah, there's no doubt about this. What
sir.
color is this?
Red color, sir.
So then what is the doubt?
Oh.
How are you getting so much, so confused in these things? Okay, then if this is callosal and it is red, what are these? I'll show you. Yeah. What are these fibers coming into view right now? In the brainstem, which are pushed on the side, which you have to save during
So
surgery.
the corticospinal tract,
So then what is the color of this?
green color, sir.
So then why are you guys so confused, man? I don't understand.
corticospinal are blue, typically.
Usually blue.
You can see the blue colors, right?
Yeah.
It's
Completely
green are the
compressed around it.
green are the projection fibers, the blue are the corticospinal, and the red are the association fibers, which are basically
Association.
going horizontally, transversely, like corpus callosum and all that.
So
So
what
those
will
are
you do for
the-
this case? I'll given you the hint. What is the diagnosis came up to as ETMR, embryonal tumor with multi-layer rosettes. What will you do for this case? Will you refer this case with biopsy to RT and CT, or will you not do biopsy and directly send the patient to RT and CT? What will you do?
So we'll first do the biopsy and then we'll send the
Biopsy is
patient.
done. It has come ETMR. Okay. Now,
Sir, it is a radio-resistant tumor, I think. So we'll send the patient for CT. Not sure.
that is why this question has been asked. This is completely resistant to RT and CT. Patient is a 2-year-old, I told you. What will you do for this case? Are the tracks involved by the tumor?
No, sir, they are displaced by the tumor.
Is there a clear plane around the tumor?
Yes, sir.
So then
We
what
can
will you do?
decompress as much as possible.
How will
Maximum
you do?
safe resection.
It's like I have to
Which approach?
just answer fully. Do you want to get additional imaging in this case for something? This is exit
Right.
exam, man.
So we can get an MRS done for the.
Maras, why do you want to do that? You already have the diagnosis, right?
Yes.
I mean, assuming
What,
it's you have
what
the
do you
diagnosis.
suspect? Somewhere else can the tumor go?
Sir, it can go caudally, so we can get a spine screening done as well.
ना हिंट नहीं होता है यार tumor तो हिंट आया था चल ठीक fine Prashant your this thing
Yeah.
I think someone has written telovillar, so that might not be the ideal approach for this case because the corticospinal were displaced posteriorly. So we would like to go more of a retrosig approach, I would say. Okay. Just to add on to the discussion.
Harsh, can you see my screen?
नहीं Prashant sorry do you want me to mail you can mail me the PPT if it is not coming just share the screen once more we can see it
Yes.
now yeah
You can see. So this is the first one. It's relatively easy. A 71-year-old female came to the hospital with left-sided headache, right-sided upper and lower limb weakness since 5 months. These are the diagnostic images. And these are the questions. What is the likely diagnosis? Who's going to answer? Amol sir, you can, and Deepak sir, you can go ahead and ask your own questions.
Okay. So, Vartika, you are answering or Vimal? Whose turn is this?
Sir, it looks like a left parietal meningioma.
Okay.
is this parietal
Frontoparietal.
Can you see the central sulcus in the CT?
So this is a.
Yeah. What are the other, telltale signs that it's a meningioma in this based on the radiology?
So can you please zoom our image a little?
So this is plain CT. This is contrast CT. Can you get some additional information on this?
So there is a dural cleft sign which shows hyperemia, which tells us that this is a meningioma.
What about the bone? Anything happening to the bone?
Hyperostosis.
So it looks like there is the involvement of the bone, dura and bone as well in this case.
There is hyperostosis, and is it involving the sinodural angle?
Yes, sir.
Yes,
So
sir.
what the diagnosis is? What is the diagnosis then?
Probably parasagittal meningioma.
Yeah, it's more like a middle third parasagittal
Parasagittal
meningioma,
meningioma.
right? With perilesional edema, with bony
Yes, sir.
hyperostosis, and apart from that, there is a dural tail.
And there is calcification of the meningioma.
Yes. So that's very important, which Dr. Prashant told that it's a non-contrast CT. The above plate, above row, and the below is contrast. So that's very, very important because surgically you have to be ready with different modalities to optimize it.
So, what is the classification of these type of meningiomas?
Sindow's classification. sir.
Sindow's classification.
Okay. And what are the common modalities of treatment?
So patient can be subjected for a frontal craniotomy and excision of the tumor, followed by, depending on the amount of residue left back and the grading of the tumor, patient can be subjected for.
Again, which craniotomy would you like to do in this?
I'd go with the frontoparietal craniotomy, sir.
Frontoparietal. Just on one side or do something
Sorry,
else?
on a left frontoparietal craniotomy, sir, which crossing the midline.
Yeah.
Crossing the midline. Why
Yes.
do you cross the midline?
Yeah.
The sinus can be exposed because the vascularity will be from the fox. So devascularize the tumor first,
Mhm.
then develop the tumor and remove the tumor.
And also you can control the bleeding from the sinus
Yeah,
much better.
sinus injury.
Yes, sir. Yes.
So that's very, very important. Okay. Especially if it's a calcified meningioma, you don't want to struggle,
Yes, sir.
and your
I mean,
incision and exposure should be
yeah.
bigger than the lesion itself.
Correct. Yes, sir.
So what are the outcome determined apart from, I mean, what are the factors predicting the outcome in tumor recurrence for meningiomas?
So the amount of
Sir.
residue left back from the MIB index.
Not just MIB index, what else? What the grade of the
Grading
tumor?
of the tumor, sir. Grading of the tumor.
Grading of the tumor.
Apart from that, surgically, anything based on extent of resection?
And the
Which
residue of what is
complication?
left back.
No. What is the grading of the resection that we follow for
Sir,
meningiomas?
Sims.
Sims grading.
Simpson's grading system.
Simpson.
R0 resection has been achieved or not?
So will you be able to achieve R0 resection in this?
I'll leave the tumor that is attached to the sinus.
Unlikely. Sir.
And then would you want to have any specific sequence done apart from these images to be able to plan your surgery and without harming the patient?
Yes, sir.
So DTI imaging can be done.
DTE sequences has to be done.
DTI. What would
DTI
DTI
And
help?
the MRV has to be.
Yeah, MRV.
MRV is more. Yeah. See, someone has written. I think your audience is smarter than you guys. So I think
So
it's
which structure is at the maximum risk which can have sequelae
Hmm.
in this patient?
Robotics.
Apart from the brain, because if it is grade 1, it should be extra-arachnoidal. So which structure here you'd like to preserve, which is at risk at this location? Any important vein here?
very, very important.
Which vein?
So bridging veins, sir.
Which bridging vein?
Yeah, there
There
must
is
be
a
a
name
name.
to it, right? It's already answered. You can read it.
I think next time we have to do a blinding for the.
There are three important
I'm
veins.
just curious. Any tumor in neurosurgery where you do R0 resection?
I know.
Since
R0.
that word that was mentioned, I'm very, very curious.
Yeah, I was like head and neck oncology.
Okay, so central, pre-central, and post-central. These three veins are important here. So you have to see in the venogram or surface MRI sequences of contrast. Where are the veins? How they are displaced, and you have to preserve those veins. Okay, during opening the dura and during resection of the. Okay.
Okay, I'll proceed to the next OSCE, sir.
Yeah.
Yeah. So this is a 12-year-old child with normal milestones, operated twice for tumor and tumor removal, and presented to us with headache and left side hemiparesis. So can you analyze the scans and get as much info as you want, and then give us the differentials and management options?
But it looks like a cystic lesion.
Okay.
Which
Where?
is there?
So third ventricle maybe.
Fourth ventricle through. Can you see the tent? Na? In sagittal, it is above
Right
tent.
thalamic muscle.
Posterior to thalamus present.
Posterior to thalamus.
Posterior to thalamus.
Why are you saying posterior? Okay.
See the T2
Yeah.
MR images. See the opposite thalamus, normal thalamus, and then you can interpret where the lesion is. Would you identify the normal thalamus on the left side?
Yes, sir.
No, you see the opposite side thalamus. So what is this lesion?
It's right thalamopedunculair mass.
Mass, which mass?
Cystic mass.
No. Yeah. So what is the differential diagnosis?
It's been operated twice already. It has come back again. And there is something written in the history about the milestones, and there is compression on the midbrain as well. So what could it be?
Mid-line
Euro
glioma, sir.
You have got the contrast sequence, you have got the T1 sequence, you have got everything. T2
Gradient.
contrast.
Yeah.
So it could be a neuroglial cyst.
But then why operate it twice?
Recurrent.
Mhm.
It could
The
be a
surgeons had
mid-line
done a
glioma.
good job. It is a recurrent lesion. It is not a residual lesion.
Mhm.
Mid-line glioma, sir.
It's an off midline structure. I
This is
mean,
not a midline.
any other cystic change visible there? You can see the approach also, right? I mean, you can see the scarring in
Yeah,
the brain.
yeah.
So can you try and analyze based on that what it could be?
Also in scan below, you can also see bilateral shunting. So that
Yes.
also had to be done. Just additional information. So this was a recurrent pilocytic astrocytoma.
Typical for this age, pilocytic and thalamopedunculair region, one side, young kid, cystic. Solid part has already been taken out. Now
Yeah.
it's just probably the cyst part is sort of reformed and causing a little bit pressure on the thalamus and the posterior limb of the internal capsule.
What management options can be given to this kid who is a small kid but has hemiparesis? Something has to be done. So what can you offer to the kid?
Probably this is the place where you should say DTI rather than saying in the previous case.
मैंने जियो में DTI कराया था. So which surgical approach, Vimal, would you like to go in if you want to do surgery or do something else, like whatever
Yeah.
thing comes in your mind, you can talk.
Very, very elegant approach without touching the cortex at all. It's answering now has gotten a lot of issues. Don't type, please.
So we can go above like the cerebellar region. We can go via plane between cerebellum and tentorial surface.
Is there a name to that approach?
Supracerebral infratentorial approach.
What are the positions that you do, patient? What are the types of positions that you have for that approach?
So we can do it in the sitting position.
If there is
or
a high risk, then
It got approved.
anything else? Any other approach? Any other position rather? Something related to a aeroplane which has been banned nowadays.
Concord.
Yeah, Concorde.
Concord position. Very good. Can we do stereotactic aspiration of the cyst?
Yes, sir.
Yes, sir.
Okay, sir. That's already 5:56.
Yeah, I think we can.
Sir, you can analyze both of them
And feedback, sir,
yeah.
for both the candidates.
Okay, sir, पहले आप बताइए.
Yeah.
Which type of analysis I have to give?
Sir, मतलब कुछ feedback, how can they improve and what all
Vimal
areas they need to concentrate in?
Vimal has to concentrate more on the clinical history and examination part. So basically, more history, more examination.
Yes.
Because you presented cervical spine, so that could have been more elaborate, even history. So you missed the profession part of the patient and cervical spine itself in examination part. Vartika was okay, but she didn't want to commit. So if you feel something, you commit it. So, I think otherwise she was fine. Okay.
I agree with Jha, sir. I think Vimal and Ratika, both of you have done a wonderful job. But I think there is always scope of improvement, and we all have been in the same boat that you are presently in. So work hard on your clinical skills and try to fish out diagnosis more precisely, and be very clear in your thought process of analyzing symptoms and how they whether something merits to your adds to your examination history, and then to final clinical localization, and then you look at the radiology based on that. And Vartik, also you presented well, and a very extensive history analysis, everything is fine. But you can probably, like sir said, you need to commit to the diagnosis, and then if you find something intraoperatively, then you can always revisit and adjust your findings and differentials accordingly. Plus, you need to analyze the radiology better. Your analysis of radiology is still not completely up to mark. You, as a management, I mean, as a clinician, as a neurosurgeon, you need to read the radiology yourself so that you are not dependent on the radiologist for telling everything. So if you do that, your surgical planning, whether it's anterior versus posterior, whether it's endonasal versus transcranial, would be more precise, and you can counsel the family and the patients much more better. Okay. Otherwise, excellent demonstration by both of you. I must congratulate, and all the best for your future.
And
Thank you,
remember
sir.
that, remember that history presenting a plan and history of presenting a plan. This makes the 85% of your performance in the exam.
Yeah.
And that, so presenting a plan and history of presenting a plan. This usually leads, you have to believe that it leads to the correct diagnosis if you do it properly. Okay. So believe it and then work harder. Okay. All the best.
Thank you, sir. Thank you to both the candidates. Thank you, Harsh.
Thank you. Thank you.
Thank you,
Thank you,
Harsh.
sir.
Thank you, Prashant. Thanks,
Thank
all.
you, Amol sir. Thank you, Joseph. Thank you so much.
Yeah,
Thank you, sir.
Thank you.
all right. And to the audience, I think they answered a lot of. There should be, I think, a next time buzzer round for them to answer and get some
Yes.
reward points, or I mean,
We'll
there
keep
should be an
a
impetus for them to
bonus
follow.
OSCE or something.
Yeah, and
Yes, sir.
you order a blanket chocolate or something to their residence wherever they are, and I think it's a good
Sir,
idea.
none of us, I think, are in private practice. So current situation के हिसाब से let it be.
Thank you, sir.
Okay, sir.
Chalo,
Okay, sir.
brownie points are, it's okay. I think not brownie
Yes, sir.
then.
Prashant probably can handle
That
all
is
the
okay.
Yeah,
Thank
expenses.
you.
Okay, sir. Yes, sir.
definitely, definitely.
Thank
All
you, sir.
right.
Thank you.
Thank you. Thanks for everything. Thank you. Thank you. All right, guys. Now
Thank you,
chin
sir.
up. The exam हो गया अब relax करो. Pass हो गया तो don't worry. Okay. All
Thank you,
right.
sir.
Yeah. All right. Bye.